Good afternoon, everybody. Uh, and we had lots of arterial cases, so we'll shift the gear on the venous side. The mission is keeping the AV axis alive for hemodialysis. So I'm presenting a case of 48 years old female, morbidly obese, hypertensive, CKD5 on maintenance hemodialysis. She had exhausted all her access, including IJVs. She had 2 failed fistulas. She was not a candidate for CAPD, renal transplant. She underwent AV graft on left forearm. It was a forearm loop graft. Had a dialysis for 3 or 4 weeks, and then comes to the emergency with the history of that the technician was not able to cannulate. There was no bleed back. Local examination, we were sure the graft is thrombosed. She underwent ultrasound, which showed the thrombus burden in the loop graft. So that's the loop graft, that's the apex. So we proceeded, took access into the arterial limb, directing towards the central vein using a 16 gauge cannula, and a 2 milligram TPA was injected. In an hour, patient was taken to the angiography suite, and we did the initial fistulogram, which showed completely thrombosed loop graft with stenosis at the venous end of the AV graft, and then there was a central venous stenosis. Here you can see the loop. So that's the initial, this is the end of the graft, venous end of the graft. That's the outflow vein. And then she had a central stenosis, probably secondary to multiple prior temp IJ catheters. So after this, we did a multiple balloon angioplasties, as we still don't have angiojet, Tiratola, and other thrombectomy devices. So all we had was a balloon. So balloon maceration of the clot was done. So after that, we restored the flow. Central venoplasty was done. So this is how the loop graft opened. The central venoplasty was done. So these are the still pictures. That's the thrombus-laden graft. So this one is the, I think it's not working. 2 sheets were inserted. The one was towards the central vein. So this is the directed towards the venous end. The other sheet was towards the arterial end of the AV graft. So we did a balloon embolectomy, and these are the picture representations. So this is the Fogarty. Everything was done percutaneously, and these are the final pictures. She goes home after the dialysis. The dialysis was done on the same day after the thrombolysis, pharmacomechanical thrombectomy, I'll say. Had a dialysis, went home. 3 months back, she comes with the same history. Same procedure was performed, and we knew that as the most prone site for stenosis is the venous end of the AV graft. So here you can see right here. So again, there was the same problem. So we went ahead, and a stent graft was deployed. So this is the final picture. Flow was restored. The central vein was fine at this time. These are the still pictures. And then she again had dialysis, goes home, comes back at an interval of 6 months. So you can see again the venous end of the stent graft. So this is the area which is prone to neointimal hyperplasia. So she had that stenosis, and the central stenosis was again there. So we went ahead and did a venoplasty. But as soon as the venoplasty was done, right on the table, she complained of severe pain. So we knew there was a rupture. So this is how, after the rupture, there was a venous compression going on. So another stent graft was deployed. So after the stent graft, the flow was restored. And at this time, we also stented the central one. So she's having regular dialysis, and the graft is functioning well since last 15 months. She's on regular follow-up on Doppler, and that's it. So the conclusion is like AV graft thrombolysis is difficult. Even open thrombectomy is not easy, and this can be easily done completely percutaneously. We don't have devices like angiojet, Tiratola, and other mechanical thrombectomy devices, but still, with the help of TPA and balloon and the stent grafts, the patency can be restored, and it works fine. Thank you.
Thank you very much. We have 1 minute for questions in case anybody wants to ask. Our final contestant.
Would you not have liked to revise the graft rather than, a lot of hardware has gone into trying to salvage this graft?
Yeah, sir, but what is the option to revise? We don't have any option. She doesn't have a good vein anywhere. This is the only thing. She had a central stenosis. Even if you place a jump graft, that vein, it's again going to stenose at that point.
But if you review what would be the natural history of this particular situation that you've created, how long do you think this is going to last?
Sir, the studies have proved it can go up to like 5 years. So, I mean, yeah, it's a tough situation, but I think the best way is to go endovascular nowadays. Thank you.